everyone. Thank you for attending the Total Joint and Hip Fracture Program Leader Forum today. We had the slide up previously to talk about the teleconference piece of it. So basically what we're going to do is we're going to have you all on mute while we do some of the introductory slides, and then what we'll do is open it up to all of our service line leaders and program leaders on the phone to ask each other questions or to share success stories that you've had in these areas that we'll talk about for the joint replacement programs and the hip fracture programs. When you do ask a question, we would like for you to state your name and your hospital so that everyone knows where you're coming from during this phone call today, during the forum today. So this morning for some of you, this afternoon for others of you, we'll have two speakers today. Myself, I'm Jenna Desormier, a Senior Product Lead with Accelero Health Partners, and my colleague, Dawn Demarest, who's also a Senior Product Lead. So we're responsible for improving Accelero's product portfolio and ensuring all projects are implemented accurately and successfully at our partner hospitals. I have a background in physical therapy where Dawn has a background in nursing. So today what we'll do is we just went through those forum logistics. We're going to talk through total joint replacement and a couple of areas, and then again hip fracture with a couple of other areas as well. So why we think it's important to have these forums for our partner hospitals is because it's this confluence of three different pieces of evidence or experience. So you bring your personal experience to the table, then there's also your colleagues' experience where you can understand where they're coming from, and then of course expert knowledge and evidence from the folks here at Accelero Health Partners. So what we wanted to share with you was the results of our survey that we did before this forum, because we know that many of you have asked to speak to your colleagues and what are they doing and how have they resolved problems that you may be having. So we wanted to get everyone together on the phone for this. What we did was sent out a survey prior to and asked you what are the topics that you would like us to discuss and like your colleagues to help you with. And the top three areas for joint replacement were day of surgery rehabilitation, preoperative optimization, and a post-discharge pathway. So those will be the three areas that we'll focus on today for joint replacement. For hip fracture, they were slightly similar with we've got patient optimization and door to the OR in 24 hours, but we also have length of stay management and the role of the navigator. So those will be the topics that we'll be focusing on for hip fracture. So we're going to start with total joint replacement, and the first topic was preoperative optimization. So really the goal of optimization is to prepare the patient physically, socially, and mentally for the procedure and ensure the patient is in his or her best health prior to surgery. And really the large elements that take up or make up optimization is patient education and preparation, a comprehensive medical evaluation, and then reducing any risks that are identified for that specific patient before surgery. One of these pieces that comes up that can be an issue is the timing of all of these elements. So one thing that we try to help our hospital partners do is set up that preoperative timing. What happens when? What should happen in the physician office? What should happen anywhere from 4 to 12 weeks before surgery, a couple weeks before, and then a couple days before, so that you can plan this out. So this would definitely be something to work with your hospitalists, your surgeons, your anesthesiologists, your pre-op group that works to clear the patient, and then your nurse navigator to understand and really write out and say, this is what's going to happen when. Definitely in that physician office visit, you want to do some of that patient education and start that messaging of the patient as to what they should expect. 4 to 12 weeks before, and that really is dependent on how far out your surgeons are scheduling their their surgeries, look to do that formal patient education. So whether it's a class, whether it's a online tool, or whether it's a patient engagement tool that they're interacting with via their phone, starting that education and, again, preparing them for the visit. When you're getting a little bit closer, that's when you start doing the formal clearance process for this patient, getting them in to their PAT appointment, and then seeing what areas of risk are they and what different options you have for reducing that risk prior to surgery and then while they're in the hospital. And then, of course, a couple days before surgery, initiating your SSI protocols to make sure that that patient is ready to go, making sure that the office staff has shared all the information with the hospital staff so that we've cleared those patients and we're ready to go the day of so there aren't any problems or cancellations. Second piece, or second key element, is the process. So what process works best for your hospital? Is it best for that optimization to be an ortho-only pre-op clinic so that everyone comes through, everyone sees the same people, has the same information shared with them, and it's all in-house? Or does it make sense for your population and your politics in your area for it just to be PCP-owned, where everything is pushed out to the primary care physicians? It may take a little bit more to collect all that information, but it may be the right option for you in that area. Or it could almost be a split of that, where it's that high-risk only clinic, where you're assessing risk prior to with a nursing phone call or that PCP visit beforehand, and then putting those high-risk patients into a pre-op clinic, and those low-risk patients can stay with their primary care physician for clearance. Lastly, the idea of having everyone agree to a risk identification and reduction protocol. So what are the comorbidities or indicators that are important to look at, to identify and test prior to surgery? Who's high risk? And then if they are, what are you going to do preoperatively, and what are you going to do while the patient's in the hospital? And this is just a sample of what one of our partners put together from information from the literature, information from their experiences with their patients that they see all the time. So getting the group around, which would be anesthesia, hospitalists, and surgeons, and agreeing to, this is what we're going to look at, this is go or no go, and then this is what we're going to do afterwards. So key pieces to that optimization piece of it. So what we'd like to do now is open up the lines for you all so that you can share your successes when it comes to preoperative optimization, or if you have any questions for your colleagues across the country and anything specific regarding what they've done or how they've solved problems that you're having. So what we're going to do is we're going to, in the process of unmuting you, so if you can mute yourselves right now, unless you do have a question or a success story to share, that would be fantastic. Does anyone have any questions or anything to share as far as preoperative optimization goes?
Hey, Jenna, this is Sarah Holman.
Hi, Sarah.
How are you?
I'm good. How are you?
Good. Hey, I just wanted to share the tool that we've been using in addition to some of the things that you guys have provided us. Our nurse practitioners are using that ACS surgical risk calculator that is a tool out of NIPSClip. So they are documenting that surgical risk on the day of the joint camp. So they can identify if there are any issues, comorbidities, how much their risk is with percent discharge to a skilled nursing facility. And we're getting to a point with that tool that we've been able to validate the data. It's pretty spot on, and the patients that they consider to be high risk typically either get canceled or readmitted. So we're coming up with criteria then based on this data to cancel or postpone surgeries until further optimization can be done, depending on what that reads. And for us, it's a 10% or higher complication rate. The patient needs to be either optimized or canceled. And then if it's a greater than 50% chance of going to a skilled nursing facility, we're reassessing that fast. And do we need to work with our partners, NIVs, that we have our embedded nurse practitioners with, to give them a heads up that these are the people that will be coming to our facility, to your facility from us, and how do we make that a smoother transition to get them there quicker.
That's fantastic. I'm glad you shared that. And one thing that I was happy you started to speak up, because I think you do something interesting down there, is you talked a little bit about your embedded physicians at these facilities. Can you talk a little bit about how you made that happen?
Sure. So we have picked a couple of different skilled nursing facilities based on different service lines. So for orthopedics, we have 2 that are preferred providers that we are in a joint venture with that are either a 3-star or above CMS rating. And we have employed our own nurse practitioners within the facility that have a deaconess doctor that does their medical management, so that the same pathways and protocols are followed, that they're seeing these patients here, they get that same care path in the nursing home facility. And how we chose those people were basically based on that 3-star rating, but then also who is going to work with us on a true partnership, in that they're not keeping patients longer than they need to be seen. They're following our protocols and our pathways, and they have agreed to that. And then they have bed placement whenever we need those patients. And patients still have freedom of choice. They don't have to go to those places, but we definitely recommend those too.
That's fantastic. Thank you so much for sharing, Sarah. Hopefully that will be very helpful for our other partners that are on the line. And I think it's great that you're using a tool that's evidence-based to identify those patients that are high risk before surgery. That's fantastic.
Great.
Does anyone else have questions for anyone, or would like to share a success story of something that you were able to accomplish as far as preoperative optimization is concerned? Okay, so if you do have something as we get to our other topics, if something comes up, feel free to interject as well. The next topic that we're going to discuss is day of surgery rehabilitation. And so really what the expectation for these patients, these total joint replacement patients, is that they are evaluated and treated by physical therapy on the day of surgery. And there's a lot that can go into making that happen, but really what you want to make sure is that they're seeing PT, they are getting a full evaluation, so that they're getting some patient education on that day, and they're starting their exercises and some gait training on that day of surgery. So there's really 2 key elements to this piece. One is process, and then one is protocol. So making sure that the process exists, so that you will have the people that you need to in the places that you need to, with the expectation that's set that PT will see these patients. So this is a sample of an order set and a pathway, and what this is really is saying this is ordered by the physician's day of surgery, PT will see them, and we work it into the pathway so that all the nurses, therapists, case managers are trained and educated on this is the expectation that PT will be seeing the patient on the day of surgery. The next piece is really to make sure that you have a protocol. So what is the expectation of PT on the day of surgery? They will go in, evaluate the patient. What's the time length that you're expecting? Is it an hour? Is it 45 minutes? Is it 30 minutes, depending on what you have the ability to do? Is it one-on-one therapy the next day? What are you looking for day of surgery versus post-operative day 1? And again, setting the expectations. That's just a brief highlight for day of surgery rehab. I know there can be quite a few issues making that happen. So again, what we'll do is we will unmute you, everyone, so if you can, again, mute yourselves, unless you have a question about making day of surgery rehab happen, or if you would like to share a success story as to how you've made that happen at your hospital and what you were able to do, how you were able to make that happen. Anyone have a question? I heard a beep. Well, we definitely know from our perspective that one item of pushback that we get is resource utilization. I don't have the staffing, or I don't have therapists that want to stay late. And so part of that is really looking for those staff members. Sometimes what works is getting PRN staff or part-time staff that have time in the evening or in the morning, so you can extend those full-time staffers' days a little bit differently. That you can schedule a few people on at 7 o'clock in the morning or 6 o'clock in the morning, depending on when you want to get those patients started. They're ending 3 o'clock, 2 o'clock in the afternoon, but then you've got staff that comes on at 10 o'clock or noon, so they can stay a little bit longer. Sometimes it is difficult to find that staff, but I have seen it work, and there are those people that would prefer to work later in the evening than in the morning, so you have staff available to see those surgeons or to see those patients. Another element can be getting agreement from all of the surgeons to make that happen. Sometimes you can run into issues where the surgeons are okay as long as the patient gets up the day of surgery. That's all they are. Okay, they're fine with just getting that patient up, maybe to the edge of the bed or walking back and forth to the bathroom, but really trying to be aggressive and saying, listen, if we need to get these patients out in 2 days or less, we really need to go hard from the very beginning and be aggressive with these patients and do a formal PT evaluation with these patients. Get them up, get them moving, get them educated, make sure that they understand their hip precautions if they do have that, and really get them going. And I know one last item that we've seen come up as an issue to getting patients up are pain management or anesthetic problems. So they may have that dead leg feature and you don't want to get them up with an immobilizer on, or their spinal hasn't worn off yet, or their block hasn't worn off yet, or they're pumped full of general anesthesia and opioids, and they are vomiting viciously at the side of their bed. So that's definitely, if that is the problem that you're running into, it's great. It's a great first step to sit down with anesthesia and say, listen, our goal is to get these patients up day of surgery. We would love to be able to do that, but right now they're so nauseated and they're vomiting that we can't get these patients up. So are there options that we can look into that would allow that patient to be up? Different dosage on the medication, a different medication in the spinal, maybe not a continuous block, but a single shot block that's short acting. So there are options out there to sit down with your surgeons and your anesthesiologists and say, from a patient experience and really a goal-oriented perspective, we want to get these patients up. What can we do to make that happen? And there definitely is options in the literature that will support that. The last topic for total joint replacement is more definitely of a new topic, a post-discharge pathway, and we think more of our partners are interested in this because of the CJR program. Because really the hospital is now responsible for that care 90 days after the patient's been discharged. So when you're thinking about a post-discharge pathway, really that is an agreed-upon comprehensive post-discharge pathway to delineate responsibilities, timeline, and patient goals. So what is happening to the patient, when is it happening, and who should be responsible for that? So really when you're thinking about that, the elements are timing, what are the patient's goals by provider, what are the discharge criteria to and from different post-discharge facilities, and then protocols for those providers. So I'm going to go over 3 key features, which is that discharge to and from criteria, timing of these events, and then the protocols. So first of all, understanding and setting discharge criteria for these patients so that everyone, again, is on the same page. What should this patient look like if they're going to go home? What should this patient look like if they're going to go to home health? What does a patient look like if they're going to go to a SNF? So everyone's on the same page, the nurses, the therapists, the surgeons, the hospitalists, so we're working towards a common goal. And then taking that one step further and saying, if that patient did go to home health, once they were discharged from the hospital, what should that patient look like when they should be discharged from home health? What are their functional expectations? What are their clinical criteria for leaving home health and being on either self-care or outpatient physical therapy? So really going that step further and defining as a group, this is what a patient looks like that is ready for discharge from a SNF. This is what a patient looks like when they're ready to be discharged from home health, and then what does this patient look like that should be discharged from outpatient therapy when they should be done with their functional progress after their joint replacement surgery. Second piece is timing. This is definitely something that will take a lot of providers working together to understand, and part of that is coming together as a group and working towards this. So not just the hospital providers, surgeon, hospitalists, PT, nursing, but also pulling in your top SNF providers, your top home health providers, and your top outpatient PT providers, and sitting down and walking through what is the expectation. What should the patient experience in their first week after surgery if they go home? If they go to home health, what should that look like? And really trying to keep this process goal-oriented instead of saying, you know, this, they should stay here for 17 days, they should go here for 12 days, really saying, listen, this is our expectation and work back from there. If we expect that patient to be able to walk 250 feet, how long, you know, does the home health therapist think it's going to take them to get that far? If they need to be a community ambulator, if they need to be able to not be homebound anymore to be able to graduate from home health, what does that look like and how can we make that happen? So that you're delineating the goals for the patient for each week and then who's responsible for what. As far as follow-up, who's making follow-up calls from the hospital, who's making follow-up calls from the surgeon office, so they're not getting multiple calls and it feels like it's a team effort from the hospital, the surgeon office, and from those post-discharge providers, everyone's on the same page. And then lastly, developing protocols, and this is essential to have everyone seated at the table. What are the goals for the time after surgery? What are the goals for the different providers? So sitting down and saying, for home health therapy, this is the expectation for the patient as far as education, exercises, distance walked, and then also the same thing for outpatient physical therapy. This is what we see as being the protocol. You're going to come in and we're going to shoot for this goal for you to look at. That's where you really can put all of these pieces together when you're thinking about your discharge criteria, discharge from and to, and then also thinking about the timing. This kind of all of these three elements come together. When are things happening? How are they going to happen? And when are they going to happen, and who's going to be responsible for it. So definitely three key areas to putting that post-discharge pathway together. Now this definitely is a new topic, so there may be a lot of questions about how you begin to make this happen, or maybe even some of you, because of CJR, have had great success in pulling this together so far. So we'll do the same thing. If you do have a question or would like to share a success story, please unmute yourself and then share that with the group of your colleagues on the phone and then us in the room. Okay, and we expected that because, again, it is such a new topic, and that's probably why you all, a lot of you checked the box on the preoperative survey, because this is very much a new topic to even start thinking about. And when you think about starting this post-discharge pathway, that first step has to be infrastructure, is getting to and inviting post-discharge providers into the infrastructure you've already built around your total joint replacement program. So your monthly meeting isn't just the surgeons and then the hospital staff. It's the surgeons, it's the hospital staff, and it is providers from your top skilled nursing facilities in the area, top inpatient rehab facilities, and top home health and outpatient PT providers, which brings up another question, which is, well, how do you even start thinking about those preferred providers. I know you heard Sarah talk a little bit earlier about how they worked to get that and have those embedded providers. And really the first step is starting to ask them for information. Ask them for how many patients they're seeing on an annual basis. What is their average length of stay? You can go on CMS's website and look at their star rating that you heard Sarah talk about a little bit too. What are these providers? And start to put together that preferred provider list and narrow it down to, top 3, top 5 if you can, depending on how many patients they're seeing each year, and invite them into your meetings, invite them into their infrastructure, because you want them to be a part of creating this process so that everything does run smoothly. And it's not just because of CJR, it's because it's the right thing to do to make sure that the patients get the entire experience that is being set up from the surgeon's office and from the hospital, and that we continue that throughout all of the post-discharge providers. The last thing I would talk about is when it comes to this post-discharge pathway is communication and follow-up. So who's doing what and how are you going to do it? Who's following up with the patient, checking in on them, and how is that done? Are you doing phone calls? Are you doing utilizing some sort of patient engagement tool that's getting feedback from them via a text or from an email? And then how are you tracking that information? Do you have that Nurse Navigator, sitting down each Friday for a couple hours, or is it something that's happening daily? And looking at how are these patients doing 1 week, 3 weeks, 3 months after surgery, and staying in contact with them so they still have that good relationship and have that same patient experience that you've set up from the very beginning, again, in that surgeon's office or in the hospital. So just give you a few things to start thinking about on this post-discharge pathway. What we're going to do now is kind of shift a little bit to the hip fracture programs, and I'm going to turn it over to my colleague, Dawn Demarest.
Hello, everyone, and happy Friday. The first topic that we are going to discuss regarding hip fracture will be the door to the OR, and with a underlying goal of being hip fracture repair in 24 hours or less. And with that, the elements that go along with that would be the ED to admission or the diagnosis of that hip fracture, medical evaluation and the following optimization prior to their fracture repair, and then the final step before the repair, which would be the preparation for that surgery. So when we look at the emergency department, we tend to think of that as the diagnostic phase, and this is an example of a process flow that breaks it down by hours and clumps phases up in hours, and you can see within those components, or several components, we would have that hip fracture diagnosis. So how long is it taking to actually diagnose this patient? Is the patient having hip pain? Are they having an inability to ambulate? Are they elderly? Are they coming from an extended care facility? So kind of taking that look at that patient and not just waiting for that hip fracture diagnosis via radiology, but starting treatment quickly with a hip fracture fast-track order set to get them through the ED as quickly as possible, and to start the process of that medical evaluation if need be, get their labs in as soon as possible to start that treatment for the optimization. And then starting some early pain management. What are the patients getting for pain? As we all pretty much understand, these patients typically come in with a lot of pain. So how are we managing them? How are we managing those specific to the elderly patient? What is the flow through the ED? Is it quick? What obstacles are you facing within the ED? Are you transferring the patient once they're admitted right to the OR? So are they having that repair quickly? Or are they going to the unit or some established floor before they go to the OR. And then finally, who has ownership of the patient? So who is admitting the patient? Who is the consult? So do you have medical management versus surgical management? And how is that working within your facility? So with that being said, what are some partners working on as far as the hip fracture patient, specifically mostly geriatric hip fracture? How are you managing these patients from the ED to admission? Okay, so some of the common issues that we do see is that movement specifically through the emergency department. Typically, we want to get those patients out of the ED as quickly as possible and either to the OR or to the unit. What we typically find, there's not enough beds on an established floor, so the patients are ending up pretty much throughout the facility, wherever there's an open bed, thus leading to some challenges with the care of the patient as it's not specialized. The patients aren't considered a priority, so that urgency is not as urgent as it should be. So the patients are kind of placed in a room in the emergency department and or on the floor to because higher priority patients do come through, especially if you're a trauma facility or if you have a chest pain patient coming through. Typically those patients take precedence. There's delays in diagnostics. Sometimes it's not, again, not a priority to read the radiology just to confirm that hip fracture diagnosis. Pain management is a challenge. We typically see that it's opioid heavy, so there's quite a bit of narcotics being used, whereas other medications can be used via what research dictates. And then typically a lot of these patients are confused. So they're confused unless there's no family present, so it becomes challenging to manage these patients and expedite them through. So our second component or second elements are kind of coupled together, and this is an example of a process flow of a medical evaluation, kind of steer clear of that clearance piece, because really it's, as research would dictate, it's not a clearance, it's an evaluation of risk for these patients. How risky are they to get to the OR? And it's typically a balancing act. Do we take this fairly sick patient to the OR knowing that this early intervention is pretty much going to be life-saving, or do we wait because we know that this patient is quite sick? And is there other things that we can do prior to surgery? Is it going to be more beneficial to take them to the OR quicker, or do we have to medically manage these patients or evaluate them more so than not? And then we get from the medical evaluation to then we have an idea, a good clinical picture of what our patients are presenting with. So now we need to optimize them, and how far do we optimize these patients, or how high do we go in optimizing them to take them to the OR? And what would be safe to take them to the OR? So what we typically see is to establish an admitting physician and a consulting physician. So who is actually admitting? Is it the orthopedist? Is it a hospitalist? Is it a primary care physician? Do you have geriatric medicine? Do you have a geriatrician that's available, as these are typically their types of patients, and they can provide very specific advice on how to medically manage these patients without over-medically managing, And with getting them to the OR as soon as possible, they can provide quite a bit of recommendations on what is adequate IV fluids. So are we hydrating these patients? Typically, we see these patients come in and they're fairly dehydrated because they don't eat as much as they used to, being elderly. They've been down at home for a period of time, so they haven't had much intake. The patients are typically confused, and of course the pain makes them even more confused. What kinds of medications did they get? So establishing that baseline delirium assessment. And then of course consults. What are we ordering in the way of consults? Do we have just the hospitalist? Do we have the geriatrician? Or are we starting to take a look at pulmonology, cardiology, and how many specialists do we really ultimately need to get involved to get this patient to the OR safely with that early surgical intervention? And this is just a common challenge that we see is the overutilization of cardiology and placing the patients through an elaborate cardiac evaluation. So what we see here is just an example of a cardiac evaluation algorithm that is research based on what the American Heart Association recommends as far as an intermediate risk patient, which is typically what an orthopedic patient would be. And again, weighing those options, do we risk waiting a day or two or even longer to get these evaluations in, and is it really going to make a difference or on the postoperative end of things, or is the quick surgical intervention really what is going to be most beneficial for these patients? So with that being said, what challenges or what issues are we facing in hospitals? What are you seeing out there as being a challenge as far as the hip fracture patient and getting them through their medical management consultations? And how, if you do have consults or if you do tend to have a cardiac consult, how are you making that happen quickly? Okay, well, some common issues that we do see is there are multiple consults, often too many according to what the research dictates. Really the early surgical intervention is what is most helpful for the patients as far as getting them mobile as soon as possible and starting that physical therapy and getting them back to or better than baseline when they came in. And then once we also find that the consults that are ordered or that are established and that we've all agreed to are taking too long. Typically the consults have 24 hours to see the patient, so already you're eating up another additional 24 hours of that patient's time and delay to the OR. Typically we find that there's not a true defined patient ownership of the patient. So who actually admits the patient and then who follows the patient? And what happens post-operatively? Does that switch? Does that get transferred then over to the hospitalist? And because the patients are basically more medically managed than they are surgically managed. We find that there's an overall knowledge deficit of that specialized geriatric care. So we have not enough geriatricians that are available for consultation to kind of take over the care of the patients. Find that confusion assessments, at least the established baseline, is not completed, so we're not sure how confused they are when they get to the floor or when they're post-operatively. Are we making things worse? What is the factor of medications in all of their confusion? And we know we don't want to be delirious. We don't want to invoke delirium in these patients because typically they don't get a lot of their baseline back once that happens. So the delirium assessment, what we find as research would dictate that it should be done on admission. So if it's not done in the ED, I mean, typically the patients aren't admitted in the ED. So as early as possible when they hit the floor, or if they're going to the OR quickly, we're seeing hospitals use the mini-CAM or the mini confusion assessment method. So it's much shorter than what the traditional assessments have been. There's also a mini cognitive assessment or a mini cog that's available. We see a lot of research that is pointing to those two. Again, quick, easy for the patients and more simple for the staff to fill out as they have multiple things to fill out. We're also seeing inadequate hydration. So as we said earlier, the patients tend to come in fairly dehydrated. So how much fluid are we giving preoperatively and intraoperatively? I mean, keeping in mind that many of these patients are fairly not well, so they typically have some underlying congestive heart failure or other medical conditions that would dictate lower IV fluids or hydration, but also their kidney insufficiency or renal insufficiency. So we want to make sure that they're adequately hydrated, because that could also have some challenges with delirium. And then, of course, the medications not being adjusted for the geriatric patient. Patients typically come in with multiple medications, so what are we doing to adjust those medications while they're in the hospital, both preoperatively and postoperatively? So the third element would be the preparation for surgery, or basically that final prep, and as you can see, this is a hours 12 to 24. And what we're doing in this stage is reviewing the diagnostics. Has anything changed since their admission? What have we done to optimize the patient? Did it actually work? Are the labs improved at that point? Is it safe now to take the patient to the OR if it wasn't safe before? A completed H&P, who's responsible for that? Is it the orthopedist? Is it the medical management piece of this, the primary care physician or the hospitalist? And then the patient goes into the OR for surgical repair. What kinds of issues or challenges are you seeing out there regarding the final preparation for surgery? Let's open up the lines for that. Okay. Some of the common challenges that we have seen are that the medical clearances aren't completed and the diagnostics aren't particularly ready, or there's some last-minute changes that happen. As we know, some of these geriatric patients can change fairly quickly. So who has that final say to actually review the diagnostics and those final medical clearances? The OR is not ready. There's no dedicated trauma room, so do we have to call a team in? What is the coverage on the weekends and in the evenings? That emergent versus urgent type case, these cases, are they really an emergent case? It's not really a life or limb type situation, so basically these are deemed as an urgent case because really that surgical intervention is what these patients need as soon as possible.
Dawn, I do have a question about the diagnostics not being ready and the medical clearances. It feels like it's similar to the idea of the joint replacement patient, where you're getting people to agree this is what we want the patient to look like before surgery. Is it very similar for a hip fracture patient, or is it different?
Well, it is, and obviously the only difference is you don't really have a lot of time that you would have. These aren't well patients typically. So for a elective hip and knee replacement patient, you have time on your side and you have choice. Obviously these patients did not have the choice to have this fracture. So it does mean that there has to be a partnership between cardiology. Typically we typically see the orthopedic surgeon, the medical management, whether that be a primary care physician or mostly hospitalist, and the involvement of a geriatrician if you have one. So that requires a discussion, a sit-down discussion of what to us, what do we want to see as what is necessary before we take the patient to the OR? And do we really need everything that we may have been doing prior to? Is it really a necessity, and what's more important, that or the early surgical intervention? So one of our second elements would be length of stay management as far as the hip fracture patient goes, with an overall goal being prepare the patient for discharge to their next level of care by postoperative day 4. Those elements being adequate pain control, early ambulation, so how quickly are the patients getting up post-op? Are they getting up on post-op day 1? Are they having some kind of activity or PT evaluation day of surgery? Are we seeing that they're not actually being as mobile as we'd like to see until day 2? So with that, are they having that progressive rehabilitation? So not only are they having rehab, and when are they having it, but is it progressive in nature? Are we trying to get our patients back to that baseline, but can we push them a little bit further and get them better than baseline? Early case management, we see a lot of hospitals that have case managers in their emergency department, and if they are available at the time to start seeing the patient, if the family's present, to start that early case management intervention. Most of these patients are going to go to a skilled facility of some sort, extended care facility. They're not going to go home for the most part. So can we start getting that selection? Can we start talking about insurance coverage, patient or family preference, and start that as early as possible? And then the management of postoperative complications. What are we doing to, once the patient comes to us, what types of complications are we seeing, and then how do we adequately manage those so we can get that patient on to their next level of care, either by managing those complications as we see them or avoiding them altogether. And of course, the specialized patient and family education. What are we doing to educate these patients specific to hip fracture? And more importantly, what are we doing to educate the family if they're present? As you know, this is a traumatic event for the family, it's a traumatic event for the patient. So unlike an elective hip replacement or elective knee replacement, these patients aren't always expecting what they're going to do after this after the surgical intervention. So similar to the elective hip replacement and knee replacement, we see a hip fracture clinical pathway. We see postoperative order sets being used. So it's very similar in that fashion to having specialized care for the elective joint replacement. This is just taking it that step further and having these same concepts for the hip fracture patient, knowing that these patients, again, aren't elective, so you have to take that into consideration. Making sure that you have an anticipated length of stay. A lot of times we don't see that this is what the expectation is, that we're going to have the patients here 4 days. What we typically see is, oh, those patients, we're not sure how long they're supposed to be staying. So really setting that expectation, we do that by having an order set. We have good pain control that's adjusted for the geriatric patient within the order sets that are research-based. We then go further to have this complication prevention and risk reduction. What are we doing to avoid some of our common complications, which would be specific to each organization, but what are we doing to avoid them, and once we start seeing them, what's the early intervention? And then we see some specific patient and family education. So what are we handing to the patients? What are we telling them about their surgery? Do they even understand what has been, or how that fracture has been repaired specific to their procedure? And what precautions do they need to follow? What's their medication management? So with that being said, what types of challenges are we seeing out there in regards to length of stay management? For instance, what are some challenges with physical therapy and early intervention? What is some of the pain management protocols that you are seeing? And what types of complication reduction and patient and family education are you seeing out there? Okay, well, some of the common issues that we are seeing is there really is no defined order set. We typically see that there are some trauma order sets or orthopedic order sets, but they're not clearly defined for geriatric specific patients. And with the rehabilitation protocols, we're not seeing that early progressive ambulation as you would see in an elective case. So not as much focus on that early rehabilitation. Seeing some challenges with case management, having many of these patients not having family present. When can case management see the patient? If they can't see the patient in the ED, how soon can they see them on the nursing unit, either post-operatively or preoperatively?
I know, Dawn, that's been a problem for just total hip and total knee replacement patients, getting case management to see them early. And sometimes we hear that, you know, on the weekends because they have fewer staff on the weekends. So that may be something that the hospital has to invest in, is that you can't run a 24-hour hospital with just a minimum staff on the weekend. So just the same with total joint replacement and, you know, running like 1 or 2 PTs on the weekend and 1 case manager for the whole staff is really saying this is something we want to invest in for our patient experience. It's the right thing to do to manage these patients. So sitting down and discussing how are we able to do this? Do we need to look at shifting joint replacements earlier in the week so we have that spot for those hip fracture patients in the weekend, or do we need to formally invest in more case managers on the weekend, more therapists on the weekend to take care of definitely those hip fracture patients, but as well as those total joint replacement patients.
And that's kind of what we're seeing, and not just a case manager, but also social work and kind of expanding that role to include that discharge planning sooner than later and extended into the evenings. We're seeing more into that evening shift as well, as, you know, these patients do not choose to have their fracture at any specific time of day. And you know, typically you'll get a patient on a Saturday or a Sunday or 2 o'clock in the morning, and really what happens then. So that very early case management visit is pretty important to get them starting to think. If you're going to have a 4-day length of stay, they really have to start considering where they're going to go post-operatively. So finally, we take a look at the Nurse Navigator with the goal to ensure seamless process from the ED through discharge, as well as keeping in contact with those patients post-discharge, which is what we're seeing in the elective cases, but we're also seeing now with the hip fracture, and with discussion being that the hip fracture will be one of the next bundled payment, or sort of like a CGR type payment situation in the near future. A Nurse Navigator is going to be very important. Some of those elements that a Nurse Navigator takes a look at, or that works with the family and the patient, is to generally troubleshoot issues. This is not, again, a non-elective case, so there are challenges that are faced with these patients versus the electives. Patient and family education. What concerns do they have? As there's usually specific concerns with the patient population, and fear. Staff education, how well adversed is the staff at taking care of these patients? These are a specialized patient population, so how comfortable are they with getting the patients up? How are they going to, how do they speak with the family? What kinds of pain meds do they give the patients? Then we have the discharge follow-up. You know, how how are we following these patients? Are we calling them? Typically we don't make calls because patients don't go home. So if they're going to a skilled facility, how are we following through and making sure that they're following through so we can prevent a secondary hip fracture or secondary fracture anywhere? And how are we tracking those patients? As we know that in the elective cases, there's partnerships that are being formed with those post-acute care providers. Is that something that we can do and include with our hip fracture patients, similar to what we're seeing across the country? What we see here is a very busy slide, but it's an example of a process flow for a hospital with a Nurse Navigator. So really, what do their days look like, or what does their day look like when they do have hip fracture patients within the hospital?
So we definitely thank you all so much for participating in our first Service Line Leader Forum. What we will do is, from the original survey that we had you fill out, we'd like to possibly include some of your next highest relevant topics in our next one. So possibly for the next one, joint replacement, we'll discuss pain management, discharge instructions, and outcome tracking. And then for hip fracture, pain management, discharge instructions, which sounds very similar to what we need to look for with our joint replacement patients, and then adding in a rehabilitation protocol. So thank you all for participating. If you do have any questions or suggestions for future topics, please do not hesitate in contacting me at the address below. So again, thank you very much for your participation today, and have a good weekend.
Yes, thank you very much.